Hello and welcome, my friends. Sat Sri Akal, Namaskar, Khush Amded, Assalamu Alaikum. Welcome to my YouTube channel. My name is Dr. Sayed Kazmi, and today I'm going to talk about a very interesting topic, and that is acute appendicitis. So, without further wasting our time, let's dive and get started. Acute appendicitis means inflammation of the vermiform appendix. Vermiform appendix is a vestigial organ. It's a sphere organ which is part of our gastrointestinal tract. It lies in the right side of the abdomen, right lower side of the abdomen, and it is behind the first part of the large intestine, which we call as cecum. So it's the organ which lies just behind and inferior, which means down on the downside of the cecum. Now, sometimes it can get inflamed, and then we call this condition as appendicitis. So it is basically an inflammation of the appendix. Now, why this appendix gets inflamed? There are various theories about that. There is not a single theory which would say why this gets inflamed, but there are different types of hypotheses which says that these conditions, if they are present, they make it more prone for that person to develop appendicitis. So the first one is that those people who have got a decrease in their dietary fiber, so those who are more into fast foods and do not take a healthy diet, and they've got an increased consumption of refined carbohydrates, they are more prone to develop appendicitis as compared to those people who have got a healthy diet, which comprises a lot of fiber and grains. The other thing is that in all these conditions where the appendix is inflamed, basically there is obstruction of the lumen of the appendix. So the inside of the inside cavity of the appendix, that gets obstructed. Now, why it would get obstructed? Some theories, they say a fecolith, which is a small particle of the fecal matter, which is comprised of like inspissated fecal material. Sometimes it can go into the opening of the appendix from the cecum, and then it can get stuck. And as it gets stuck, it blocks the lumen, and then because the free drainage is blocked, that can lead to overgrowth of the bacteria within the lumen of the vermiform appendix, and it can get inflamed and cause appendicitis. Some people say growth of a tumor, especially if it is a carcinoma of the cecum or such types of tumors like carcinoid syndrome, that can grow in that part of the intestine, and that can also cause blockage of the lumen, and that in turn would cause appendicitis. And then another theory says that those people who are harboring certain types of parasites, worms in their intestines, especially the Oxyuris species or Enterobius vermicularis, which is also known as pinworms. If they are harboring those pinworms, they can get into the lumen, they can block the lumen of the vermiform appendix, and then in turn that would lead to inflammation, a secondary bacterial infection of the lumen of the vermiform appendix, and that is essentially what we call as acute appendicitis. Now, moving on to some of the risk factors. Remember, like, why we worry if the appendix is inflamed. If the appendix is inflamed and you do not treat it, I mean, by treatment we mean if we do not remove it surgically, then there are always chance of perforation. So where let's say if this is the vermiform appendix and you've got a block here, so what would happen? Because there will be inflammation in the distal part, it would get swollen. A time would come that it can burst open. So if you do not remove it, it can burst open, and some people have got predisposition to bursting of the appendix, and there are certain risk factors, which are number one, extremes of age. So kids who are very young, like those who are under 5 years of age, and those who are at the other extreme of the age, like the very elderly, they are more prone to develop perforation of the appendix if it gets inflamed. Those people who are immunosuppressed for one reason or the other, so either they got a primary immunodeficiency in the form of HIV or certain types of immunosuppressive disorders, or they've got secondary immunosuppression in the form of because they're taking steroids or taking other immunosuppressant drugs for one reason or the other, they can develop perforation if their appendix gets inflamed. As diabetics are more prone to develop perforation if they develop appendicitis. Similarly, fecolith obstruction, if somehow those people who are constipated, again, the theory is not that much proven, but somehow, for some reason, if the fecolith goes inside the lumen of the appendix, then Obviously, that would lead to appendicitis, but then they say that at the same time, there are more chances that that appendix can burst. Similarly, those people who have got pelvic appendix, like it's the anatomical variety where the vermiform appendix is hanging in such a position that it is pelvic in nature, like going down, extending into the pelvic, and somehow because there is a lot of space where it can balloon and immediately burst open because there's free space around it, so there are more chances of bursting open of the appendix in case if it gets inflamed. And those people who've got previous abdominal surgery, they might have like fibrous tissue surrounding the areas, and this fibrous tissue, is hasn't got that elasticity. So obviously, if it gets swollen, there are more chances that the appendix can burst in that particular area. Now, coming down to the clinical manifestation, like somebody who has got appendicitis, what are the different signs and symptoms that they present? So, starting with the symptoms. In children, most of the time, it would always start as acute, or yes, it's acute in most of the cases because there's a short history of pain in the abdomen, and that pain is usually peri-umbilical and it's colicky in nature. So, it would always start around the umbilical. So they always like point in the center of the abdomen, that it starts from there. So it's colicky, and that colicky peri-umbilical pain can stay for a variety of time. I mean, usually it could stay there for 12 to 24 hours before it shifts to the right iliac fossa. So there is always history of pain starting in the central part of the tummy and then shifting to the right iliac fossa. So this is very much characteristic of acute appendicitis. There are a few other conditions in which it can also happen, but by and large, the most important condition which you would never like to miss is acute appendicitis. So it always starts as a peri-umbilical colicky pain, comes in waves, progressively increases. So obviously, the peri-umbilical part of the pain is usually mild in nature, but once it's shifted to the right iliac fossa, then gradually it progresses. So it's usually a progressive pain. It is associated with anorexia, in which the child doesn't want to eat, so he's lost his appetite. And it might be associated with vomiting or nausea. So either they might be having frank vomiting, and this vomiting usually comes after the onset of the pain. It's not like it starts with vomiting and then they develop pain. They usually start with pain and then they end up in vomiting. So even if they're not vomiting, they might develop what we call as nausea, where they're not feeling well and they just feel sick. On the signs that usually most of these cases have got a mild febrile illness. So the fever is very much mild in nature. So sometimes it might even go undetected. So somewhere between 37.2 to 37.7. So this is very mild, or some people call it even borderline pyrexia. That's usually a manifestation of acute appendicitis. Then when you press on their right iliac fossa, the right side of the abdomen, there is localized tenderness. Localized tenderness means that it is not the whole of the tummy that is painful when you press on it. It's more of the right lower side of the abdomen. When you put your hand on that, you're palpating. The child complains that he's got pain. So either they would say they've got pain, or they would say ouch, or they can make facial grimaces, which can give you an idea that there is pain in that particular area. Similarly, if the pain is too much, they might have a bit of muscle guarding, voluntary guarding. So what happens, voluntary guarding? I mean, as you are trying to put your hand over there, they would tighten the muscles. So when you put your hand, you feel like the muscles are quite tight. And this tightening is done voluntarily because the child knows that when you put your hand onto that area, the pain would be coming. So just as a reflex phenomena, they would tighten the muscles of the right iliac fossa, and that would cause voluntary. And the other sign is rebound tenderness. So rebound tenderness, obviously, when you press on the right iliac fossa, it leads to pain. But if you keep the pressure on and you press down, and then if you suddenly release your hand, so what would happen? There would be more pain on releasing your hand rather than pressing it down. Obviously, when you press it down, it also leads to pain. But when you suddenly lift your hand up, child may even like jump because of the pain. So that is known as rebound tenderness. So once you've got this thing, then there are, there's very high suspicion or index of suspicion that this child might have got acute appendicitis. So what signs to elicit? So there are a few signs that help you in diagnosing acute appendicitis. The first one is pointing sign. Pointing sign, obviously, you ask the child where it hurts. So they say it like they would begin with that it started, like they would be pointing towards their belly button, and then they would point towards the right lower abdomen. So that is known as a pointing sign. They would be pointing toward the right iliac fossa that it hurts. So that is known as pointing sign. Then you've got what we call as the Rovsing sign. So Rovsing signs means that you press the opposite side. So you deeply palpate the left iliac fossa, and that palpation of the left iliac fossa causes pain in the right iliac fossa. So you press the left side, but it doesn't lead to pain on the left side. It leads to pain on the right side. So that's what we call as the Rovsing sign. So Rovsing sign would be present in acute appendicitis. Then we've got the psoas sign. A psoas sign is where usually it's a sign which we elicited when people have got retrocecal or pelvic appendix, because if people have got like retrocecal or pelvic appendix, and usually the tenderness might not be that much severe in the right iliac fossa. So in psoas sign, what we do is that the patient lies with the right hip flexed for pain relief, and if you try to extend the right thigh, that would lead to excruciating pain in the right iliac fossa. And then the obturator sign. So obturator sign, what we do is like we flex the hip and the knee, and we try to move the leg at the knee joint laterally. So as you move the leg laterally, what would happen is that the hip would move medially and there will be internal rotation. So for example, if let's say if this is the thigh and this is the leg, so as you do like this, so you rotate the leg, this is the leg part, this is the knee joint. So if you rotate it laterally, the hip would go internally and mean rotation. So that would cause excruciating pain. That is known as obturator sign. So obturator sign and psoas signs are important signs that you can elicit in case if the appendix is either retrocecal or is pelvic. So these two signs would be present. Usually the tenderness would be mild, but if you do these signs, the child would be having excruciating pain. So this is an important thing that you should be eliciting if rarely the child has got pelvic appendix or retrocecal appendix. Moving on to some of the areas where there will be a lot of tenderness in these areas. Number one is if you draw a line between the anterior superior iliac spine and the umbilicus. So if you 1/3 the way, or that is the lateral part, and 2/3 from the medial part, the point joining that is known as McBurney's point. So there is maximum tenderness at McBurney's point. So this is the point where there will be maximal tenderness. Obviously the whole area is painful, but this is the area, like you can point with your finger, that hurts the most. So that is the McBurney point, which lies on a line, imaginary line, which joins the anterior superior iliac spine with the umbilicus, and this point is at the junction of the lateral 1/3, and the medial 2/3. So lateral 1/3 and medial 2/3, where they join, that point is known as McBurney's point. So there will be maximum tenderness at this point. This is the obturator sign, like elicited or illustrated, where what you do is you flex the hip and you flex the knee. You hold with left hand you can hold the knee, and then you hold the leg and then you rotate it laterally. So as you rotate it laterally, the hip would move internally. There will be internal rotation, and that would cause excruciating pain, and that is what we call as an obturator sign, because the inflamed appendix would hit the obturator's internus muscle, and if the child has got retrocecal or pelvic appendix, that would be positive in such case. This is a psoas sign where you know the hip is actually extended, and that would lead to excruciating pain because the pelvic appendix or the retrocecal appendix that hits the psoas muscle. Okay. Depending on some of the special features, because the vermiform appendix can have different anatomical variations. It could be lying up like paracecal, it could be lying retrocecal, it could be lying in pelvic region. So depending on that, there can be certain, like what we call as special features. So if it is retrocecal, that it lies behind the cecum, then rigidity is usually absent, but deep pressure fails to elicit tenderness. So in that case, the tenderness will be very mild, because the appendix is like behind, it's hiding behind the cecum. Obviously, when you're putting pressure from top, that pressure is not going down and hit on the appendix. That's why rigidity and tenderness would be mild in particular case. But there might be deep tenderness is present in the loin. So because it is at the back, you press it, or sometimes what we do is we put one hand the back of the patient and then we press deeply. That might lead to more pain, and that gives you an idea that the appendix is probably lying posterior in position, so it's probably behind the cecum, what we call as retrocecum. Pelvic appendicitis, usually because it's pelvic in nature and the length is around 7 to 9 centimeters, it might be touching the rectum, and because it's inflamed and when it touches the normal organ, that it can lead to diarrhea. So sometimes diarrhea, which you might think that the child has got gastroenteritis, in fact it's not. It's simply a sort of a spurious diarrhea, simply because the appendix is pelvic and it's just touching the rectum. There might be complete absence of abdominal rigidity and lacking tenderness over McBurney's point. Obviously, why? Because again, the organ is quite pelvic down in nature. So where you're trying to press and elicit, there is no pain over there or minimal pain. There might be deep tenderness around the symphysis pubis or on the right side if you do the rectal examination, but again, we seldom do that in pediatrics. So I told you that the usually obturator sign and SWAS sign would present that are like which should be elicited if you feel like there is mild tenderness on the right iliac fossa. And sometimes this inflamed appendix might be touching the ureter as well. That can give you a bit of like white blood cells in the urine dip as well, or might lead sometimes to dysuria as well. And that can sometimes, might make that the child might have a UTI, and I told you in some cases even gastroenteritis, but it's not the case. It's simply because the appendix is pelvic in nature and it's touching either the ureter or the rectum. Sometimes it might be post-ileal in nature, in which like it is hiding behind the terminal part of the small intestine, which is known as ileum. It is one of the greatest, one has got greatest difficulty in detecting that condition, because pain may not shift. Pain might be like present somewhere between the right iliac fossa and the periumbilical region. Diarrhea is not usually present, and sometimes there might be marked retching rather than vomiting. And again, these are very non-specific signs, and that can, lead you in different directions rather than focusing on acute appendicitis. Again, tenderness, if any, would be very much ill-defined, and it might be immediately to the right of the umbilicus, which might make you think that the child has got mesenteric adenitis rather than having acute appendicitis. But nevertheless, I mean, if you are in a doubt, then again, you should be thinking more in favor of acute appendicitis rather than other conditions, because this is one thing that you would never like to miss. Now, the differential diagnosis, again, it's we don't want to miss acute appendicitis, but there are a lot of other conditions which can present more or less with similar symptomatology. So in children, in young children, some of the conditions that can present with right iliac fossa pain, tenderness, vomiting, mild fever is gastroenteritis. So gastroenteritis is one of the most common medical reasons of pain in the right iliac fossa if it associated with vomiting and profuse diarrhea. Similarly, mesenteric adenitis. Mesenteric adenitis is inflammation of the lymph nodes lying in the mesentery on the right side. And there are certain types of viral illnesses which usually start as a URI, but because the child is following their own, like infected sputum, that can go down, and that can from there, like, go into the mesenteric lymph nodes, and they can get inflamed, and that also causes pain because it's stretching of the capsule of the lymph nodes, and that can cause pain and a little bit of fever. So the pain is more diffuse in nature rather than being specific to the McBurney point. So that is mesenteric adenitis, which is again common in Meckel's diverticulitis. So in 2% of the population, kids might have got a small outpoaching at the terminal part of the small intestine, which we call as Meckel's diverticulum. So in most cases, it might present with painless massive bleed, but sometimes it can get inflamed as well. And when it gets inflamed because of its close proximity to the region, it can present like acute appendicitis. We call it Meckel's diverticulitis. Intussusception, which is another condition you don't want to miss, where one part of the intestine telescopes into another one, like the ileal or ileocolic. That can happen, and usually happens more on the right side of the abdomen. That can also give pain and tenderness in the right iliac fossa. HSP, Hodgkin purpura, in which you have got like vasculitis of the medium blood vessels, small blood vessels, that can also cause abdominal pain, especially on the right side, but usually associated with joint pains, and there might be a purpuric, a palpable rash on the lower limbs. Lobar pneumonia, right-sided lobar pneumonia can sometimes rarely present, though it might be presenting more with pain in the upper part of the right side of the abdomen, but sometimes you never know, can present as pain in the right iliac fossa as well. Similarly, in adolescents or adults, regional enteritis, so terminal ileitis, which is part of the Crohn's disease. So if somebody's got inflammatory bowel disease and they've got right-sided iliac fossa pain, that could be because of the inflammation of the terminal part of the ileum, which we call as terminal ileitis, and it usually happens in Crohn's disease. So, and it can happen in adults, it can happen in adolescents as well. Ureteric colic, somebody's got like stone in the ureter and they've got spasmodic contractions, the stone is going down, they're passing the stone, that can cause pain in the right side, though it's more of a pain which starts from the loin and goes towards the groin. Pyelonephritis, which is basically inflammation of the upper renal tract, that can also cause pain in the right iliac fossa. Again, that would be more of a pain on the back side rather than the front side, and usually associated with fever and vomiting, and usually these kids are quite unwell. Perforated peptic ulcer, rare, that most presents mostly as epigastric pain rather than right iliac fossa. Torsion of the right side of the testes sometimes can present with referred pain to the right iliac fossa. Some kids might be a bit shy to explain that where actually is the swelling or the. That's why anybody who has got right-sided abdominal pain, you should always examine the genitalia, especially if it's a male, so that you do not miss out on the torsion. Pancreatitis, again, really can happen as a complication of certain viral illnesses like mumps or rubella as well. So these things are quite rare after like universal vaccination, but you never know, sometimes they can happen. Rectus sheath hematoma, if there is like a history of trauma, somebody playing rugby, football, and being kicked or hit in the right iliac fossa, they might develop a rectus sheath hematoma, and that can also present as pain in the right iliac fossa. Right-sided rectal pain is always quite difficult to diagnose if you are dealing with a female, especially young adolescents. So Mittelschmerz, like mid-ovulatory pain, which usually occurs at the point where the ovum is released from the follicle, that usually leads to severe pain, as because it can lead to a bit of irritation in the peritoneum, especially if it is really on the right side. It can mimic pain like appendicitis. So usually a mid-ovulatory cycle pain, which we call as Mittelschmerz, can also be mistaken for acute appendicitis. Pelvic inflammatory disease on the right side tube, like those who have got risky or indulge in risky habits, they might develop pelvic inflammatory disease, and they might be a bit shy to discuss about those conditions. But remember, if it is more of a pelvic pain going down, you can think of that as well. Ectopic pregnancy, very important. All females who have got right-sided abdominal pain, it's part of the initial workup that we do a beta HCG levels, urinary beta HCG, and then you can follow up with the blood HCG levels as well, because an ectopic pregnancy, especially if a ruptured one, that could be catastrophic. So you should never want to miss that. That's why beta HCG is done routinely in all females. Similarly, torsion or rupture of an ovarian cyst can also give rise to pain in the right iliac fossa, especially in obese females. So that's why ultrasound is a good modality, because it can differentiate between these conditions. Similarly, endometriosis, in which the endometrial tissue grows outside of the uterus, that can also lead to debilitating pain in the right iliac fossa or in the left iliac fossa, and they usually got a chronic history of like cyclical pains, and they go without diagnosis. So obviously, the best way to diagnose is to do a diagnostic laparoscopy. In elderly patient, which is not our domain, there are more sinister things that can cause a right-sided iliac fossa. It could be an abdominal aortic aneurysm. It could be a colonic carcinoma. But anyhow, I don't want to go into details of that, because that's not our domain. We are mostly, interested in these three groups with the differentials, that you should keep it in mind when you are thinking of acute appendicitis at the same time. Some of the investigations, routine investigations, we always want to do a full blood count. Why we want to do a full blood count? We want to see at the white blood cells. So usually in acute appendicitis, the white blood cell count is high, and there will be shift towards the left side. We also check at the inflammatory mark, especially the high sensitivity CRP, which is usually elevated. Urinalysis is routinely done because if it might make conditions like UTI, I think that would be picked up on a urinalysis where you can get like nitrites positive in the urine. Some of the selective tests, like pregnancy tests, we would like to do every adolescent female who presents with right-sided abdominal pain. Urine electrolytes are done selectively to see if somebody is vomiting and things, to see if they've got any electrolyte derangements, because before you want to take them to the theater, something you would like to correct those things. Supine abdominal radiograph or erect abdominal radiograph, if you are thinking that there might be a perforation, severe abdominal pain, then you can do that in order to rule out free gas under the right dome of the diaphragm. Similarly, ultrasound of the abdomen pelvis, this is the best diagnostic modality in children because ultrasound can pick up inflammation of the appendix, and it can also pick up other conditions which might be responsible for pain in the right iliac fossa. And if things are equivocal on ultrasound and not able to pick up a proper diagnosis on ultrasound, then contrast enhanced CT scan of the abdomen in most cases is very sensitive and very specific, especially in picking up acute appendicitis. So these are some of the investigations that can be done. So remember, routinely we do the full blood count and inflammatory markers, and we do a urinalysis, and if it's a girl, we do the beta HCG levels. But at the same time, we will do before we take them, we can do the UNEs. In most of the cases, surgical diagnosis is made, but obviously if things are unequivocal, then obviously ultrasound of the abdomen can pick up acute appendicitis. It's quite sensitive. It's not specific, but it's quite sensitive. If not, then contrast enhanced CT has got very good sensitivity and specificity at picking up acute appendicitis. Sometimes we do use the diagnostic scoring system as well. We've got the two systems. One is the Alvarado scoring system. The other is a pediatric appendicitis score. These two scoring systems are used. The Alvarado scoring system has got a maximum of 10 points. These days, there is use of modified Alvarado score as well. There is not much difference between Alvarado and modified Alvarado. The only difference in Alvarado, you've got like 10 points in total for different features. In modified Alvarado, that is the modified Alvarado, let me write it, modified Alvarado scoring system, you have got only 9 points. So they take this off. So if you take this off, then you have got a total of 9 points. So modified Alvarado scoring system is the Alvarado scoring system minus the 1 mark for the shift to the left. So if you take out, that becomes the modified Alvarado system. So what happens, you've got like 10 points. You've got 3 points for the symptoms. So if the pain is migratory, it starts in periumbilical and it went to the right iliac fossa, you give 1 mark for that in the history. If the child has got anorexia, again another 1 mark for that. And if they've got nausea and vomiting, another 1 mark. So total of 3 on this symptomatology. Then based on the signs, for tenderness in the right iliac fossa, there are 2 marks. Then if there is rebound tenderness, 1 mark for that and 1 mark for elevated temperature. So a total of 4 marks for the signs. And then we do blood. So if blood shows leukocytosis based on the age of the child, like I would say probably rough cutoff would be white blood cell count greater than 15,000, 2 marks for that. And with that, if you see that there is shift to the left, like there is on the differential leukocyte count, there is like more of a neutrophilia or what you call as pandemia, then 1 mark for that. So a total of 10 marks. Any score greater than 7, is most probably acute appendicitis. So anybody who's got a score of greater than 7, they should be consulted with the surgeons. They probably have got acute appendicitis, while the score of 5 to 6 are what we call as equivocal, and these guys would need some more investigation, some more time. So they might need ultrasonography or they might contrast enhanced CT. But if it's more than 7, they need to be consulted with the surgeon and probably need to be taken to the theater. Okay, so Alvarado scoring system or modified Alvarado scoring system is one of the scoring systems that we use in pediatrics for acute appendicitis. The other one is pediatric appendicitis score as well. These are some of the CT scan images of appendicitis, and I would like to show you some more over here in a moment. So if I take you, okay, so let me take you to this. Yeah, so this is a CT scan of the abdomen, a contrast enhanced CT. And if I try to move it down, as you see, as we are going down, you can see the liver is now in focus. You've got, so this is the liver, this is the stomach, this is, you can see the spleen, here is the spleen. And if I go further down, as we here, you can see the gallbladder coming in. You can see the kidneys here, the right kidney over here, and then the left kidney. And if I go down, further down, more down, you can see this is the contrast enhanced large intestine. And if I further go down, so here, if you see, this is this grayish, sorry, this grayish bit is now the appendix, and you can see this is quite dilated. I mean, if we measure this, probably more than 6 millimeter. And here you can see this is the vermiform appendix, quite swollen. And probably here you can see there is a fecolith as well. Here, a fecolith as well. So you can see it's quite swollen. So this is the vermiform appendix, which is probably greater than 6 millimeter. So greater than 6 millimeter is diagnostic of acute appendicitis, and there is some stranding of the periappendicular fat as well. Let's go to the other section, and from front to back, if I move on this back system, so here you can see the large intestine. Somewhere here should be the yeah, so here you can see on this plane, you can see this is the appendix. Again, if we measure this, is probably more than 6 millimeter. You can see the lumen is quite distant, and probably this whitish dot is a fecolith. You can see the appendix is quite inflamed with stranding. This, you can see there is stranding of the periappendicular fat as well because of the inflammation. It's adhering to the psoas muscle, so you can see. Yes, you can see this is the cecum, and this is the inflamed appendix. You can see it as attenuation of the gray color over here. Probably this dense in between is a fecolith. So this is acute appendicitis on the CT abdomen. So this is acute appendicitis. Okay. So let's go back. Fine. So moving on, you have seen the CT is now coming down to the treatment. The treatment, usually one is the supportive treatment. So supportive treatment, you have, if they've been like vomiting and they have got a bit of like they are dry or they've lost some fluid, you have to pass an IV line and you have to give them IV fluid, so you maintain an adequate urinary output. You might be giving them appropriate antibiotics. Those antibiotics, number one, could be in certain countries, some antibiotics are routinely used because to decrease the chances of post-operative wound infection, or sometimes it's given operatively, if you are suspecting that the appendix might have burst and might have lead to spread of infection inside the abdomen. But the definitive treatment is appendectomy. So you have to remove the appendix. So the appendix has to be removed surgically. So usually the types of appendectomies that are done these days is conventional appendectomies and laparoscopic. Though conventional is seldom used these days, most people have now opted for minimally invasive surgery, and that is laparoscopic appendectomy. So in conventional appendectomy, what they do is usually a grid or an incision is given in the right iliac fossa, and then you have to open up, expose the cecum, identify the appendix, inflame appendix, and then you have to ligate the appendiceal artery, and then suture the base of, ligate the base of the vermiform appendix, and then cut it, and then invert the stump and close the wound. So that is what we used to do in conventional appendectomy, but these days mostly people are using now laparoscopic appendectomy. So in laparoscopic appendectomy, I will show you what happens. Usually you have to put up an operating port and a camera port. So the camera port is usually 10 millimeter and usually placed either at the umbilicus or slightly above the umbilicus. So that 10 millimeter port, you put the camera in, and then you have got two ports which are known as operating ports. So you can have one port in the left iliac fossa and the one port in the right iliac fossa. Sometimes you can have like both ports in the left iliac fossa. But anyhow, depends on the surgeon's preference. So one port in the left iliac fossa, right, one port in the right iliac fossa. So the camera looks at that, and it's minimally invasive surgery. So the structures are identified. The window is created between the base of the appendix and the appendiceal artery. So then by the bipolars, the artery is coagulated, the base is crushed and coagulated, and then it's usually cut, and a suture can be applied, and then the cameras and the operating ports can be taken out. So and just maybe 1 or 2 stitches are given. So this is minimally invasive surgery in which the child can go home within a day, within 24 hours, and has got less chances of complications. So you can see here, surgical incision in case of open appendectomy is usually a large one and leads to scarring. While in case of laparoscopy, you've got one here, 10 mm camera port incision, and there were 2 like keyhole incisions which are known as operating ports, for which you put your dissecting instruments inside and you cut the appendix. Okay, this is some of the images which have been taken by someone who was doing laparoscopic appendectomy, and here you can see this is the appendix. You can see this is the inflamed appendix attached with its mesentery. So they are just holding the base of the appendix. So here there would be appendiceal artery. So usually they create a window, they coagulate that, and after that you can see they are tying. So sutures are placed at the base, and once it is tied up, then by the bipolar it is crushed and then divided. So the appendix, inflamed appendix, is taken out, and then you can see this is the remaining stump of the where the appendix was attached. So it can be done with what minimal invasion of the abdomen, and this is the standard technique that's used these days. So some of the problems which can be encountered during appendectomy is that, like you thought it was acute appendicitis, the surgeons, they open the abdomen, but what happens is they found that the appendix is normal. It's normal, it happens in practice actually, where you think it was appendicitis, you open up the abdomen thinking you would be dealing with an acute appendix, but in fact it's a normal appendix. But even if it's a normal appendix, it's taken out, so that the practice these days is to take it out, so that in order to avoid future diagnostic problems or future appendicitis. Sometimes the appendix cannot be found, like the surgeon tries to find, so then the cecum should be mobilized, because in that case there might be an anatomical variation. It might be lying at the back, it might be hidden somewhere behind the ileum, so the cecum should be visualized from all sides to see where is the appendix. Sometimes an appendicular tumor is found. It's not an inflammation, it's basically a tumor which is like obstructing the lumen and causing the same symptoms, like carcinoid syndrome tumors can happen in the appendix as well. So small tumors they should be removed by appendectomy. If there are large tumor, then you have to do a right hemicolectomy. You have to take out like part of the large intestine because you don't want recurrences in that case to avoid future problems. And sometimes you might encounter an abscess in the appendix. So the appendix is inflamed and it led to an abscess formation. Now, if you open it up and you find an abscess formation, then it should be treated by local peritoneal toilet because it might have spread. So you just clean the whole peritoneum and then you drain the abscess and you give them intravenous antibiotics after the surgery as well. If sometimes you might come up in a condition in which the child has got signs and symptoms of acute appendicitis, but they've like developed a mass. So if they have developed a mass and they are stable, then that is not treated by surgery. It's usually treated conservatively. So you have to give them intravenous antibiotics. So you have to wait till the temperature and the pulse and everything settles down. You might have to do a contrast and Hus CT to see the extent. But if in case if child with an appendiceal mass is unstable, in that case, then you have to do a laparotomy. You don't do a simple appendectomy. You have to do a laparotomy because you don't know the extent of the organs that might be involved. So you might have to do a like big incision and see what's going on, and then might have to do certain other procedures as well. But again, if it is the child is stable, then they are treated conservatively till the mass is resolved, and after that the surgery can be done. So this was all about appendicitis. We discussed some of the signs and symptoms. We discussed the diagnosis, and we discussed the treatment of acute appendicitis. Hope you have liked my video. If you have liked it, give me a thumb up. And if you haven't subscribed to my channel, then please do subscribe and press the bell notification icon. So whenever I upload a new video, you get an instant notification that the video is there and you can watch it. Thank you very much. Have a good day and bye-bye.